Good afternoon, everyone. Thank you very much for joining us today on this half-day seminar for health innovation. A warm welcome especially to our chairman, Dr. Angatia, Executive Director, Professor Bauron, distinguished presenters, members of academic and industry partners, and all participants who are joining in online as well. So this event today is actually one of the current activities that the Council does to disseminate the outcomes of research and innovation projects that have been funded by the Council. So we use this platform not only to demonstrate the outcome of the results, but it's also as a networking platform. People can understand what's been achieved, and hopefully there should be discussions that enable networking and further development of these projects. So for today, we are going to have a total of 4 presentations. 3 presentations at the beginning are of completed projects that came under the Council's Proof of Concept scheme and the Innovation Boost grant scheme. So among these projects, we have a presentation on immersive technologies to improve health and wellness, which will explore how virtual and augmented reality can promote physical activity and mental well-being. We'll have a second presentation on AI-based food classification and recommendation system. So that will demonstrate how AI can support healthy eating and fight the NCDs. And we'll have a third presentation on assistance and medical emergency services, which will be presenting an innovative mobile app for immediate location-based medical based in Toronto, Canada. And he's going to give a presentation on advances in neurophysiology with focused ultrasound. And hopefully that will give us a glimpse into the future of non-invasive brain therapies and the growing international footprint of Mauritian scientific expertise overseas. We were lucky to be able to get Dr. Nanku. He actually wrote to the Council initially, asked for conversation with the director, and we had a Zoom conversation with him afterwards, and he's very keen to collaborate with partners in Mauritius. So we'll listen to his presentation and see what comes out of it. And hopefully, like I said, this platform should encourage discussion and further networking. So thank you once again for taking the time to be here. I now invite the Executive Director, Professor Bauron, to make his address. Thank you.
Thank you, Nitin. Dr. Angacha, Chairperson of the MRIC, co-chairs of the RMC committee, members of the RMC committee, stakeholders, health stakeholders, very good afternoon to you all. Well, we are here today, as Nitin just alluded to disseminate 3 projects that we funded at the level of the Council. And we looked into the innovative aspects of these projects before providing whatever funding. So this seminar is dedicated to showcasing the various outcomes, and we'll be very happy and very curious to have a look at these outcomes of innovative health-related projects that have been funded under les Assises de la Recherche. Now, when we talk about innovation, I would like to emphasize that through all the calls of the MRIC, Council stands at the forefront to promote research and innovation. And when we talk about innovation, I'll allude to one particular activity or to 2 particular activities. The first one being the National Innovation Challenge that we launched a few weeks ago. In fact, the minister was here to launch that National Innovation Challenge. And within the National Innovation Challenge, we are innovating by including the rising innovators and the young innovators. And we have already been, we're already obtaining a number of applications right now. And if you look at, if you watch TV, it's on the TV every day, prompting young people, prompting less young, older people to come up and indeed to apply for the National Innovation Challenge. So I make a special appeal to all researchers, to all people who have ideas throughout the country to come forward, because it is an opportunity for you to expose your idea, to develop your idea, and to earn some seed funding to develop these ideas into entities, into endeavors, but possibly could develop into enterprises. So an appeal to participate in the National Innovation Challenge. The next issue I wanted to allude to is the Global Innovation Index. We had the report out in September, that is last month, and we have the pleasure to announce, well, it was announced, it is in the report, and the minister also alluded to this in his press conference. We have gained 2 places in the GII. But what is most important to note is that Mauritius has been described as the most effective innovation climber since 5 years. So in 2019, we were 82nd, and today we are 53rd. So Mauritius has been commended for its innovative practices, and more particularly this year, it has been commended for its innovative outputs. We were poor in outputs some years ago. We have been able to catch up, and now we have gained 23 places in terms of innovation outputs. However, we still have a lot of efforts right now for innovation inputs. Innovation inputs means investment in innovation, investment in development, investment in research. We are still at 0.23% of GDP, which is very low compared to Singapore. So we have there a lot of efforts to do, and the MRIC is putting all efforts through the team present here as well, the GII team. We are responsible for around 8 to 9 indicators, and also coordinate all actions for the country. And we have yesterday finalized the technical committee that is being chaired by the Honorable Minister for the GII. And we indeed look forward to progress in confidence and in humility, but there's a lot of work to be done. So having said that, I wanted to make a point on this, because if you look at the press, if we had fallen 5, 6 places, it would have come straight. Mauritius has fallen in the GII, but Mauritius has improved. There has been only a small place in the press in 1 or 2 newspapers highlighting this. Well, most probably we have most important news for press people to publish, but this is very important for our country, because it eases business, it brings investors a lot of, I would say, networking. So this is why I wanted to make a point about the GII. So regards to, we should also note that we have maintained our first position in Africa, and since numerous years, and have improved by 3 ranks regards to the upper middle income group, from the 9th to the 6th. So these were some facts I wanted to share with you. And coming to today's event, these projects that are being showcased today, that have been presented, they emanate from les Assises de la Recherche, as alluded by Dr. Gopal. And we had received in that particular thematic for innovation, health innovation, 42 applications, of which 12 were approved to the tune of 12 million rupees. So the health innovation focus theme in that focuses on building a healthier and more resilient society through technology-driven solution. And as you would see, all 3 projects that will be presented are technology-driven or technology-based. This is where we need to go, where we need to achieve so that one, we climb again the ladder of the GII, but also we provide, I would say, immersive new technological solutions for the health sector. And MRIC will continue to bridge the gap between academia, industry, and also, in that particular case, healthcare professionals. So, regards to the projects that we are having today, Nitin indicated immersive technologies for health and wellness. Well, it's a project that will address an emerging frontier in preventive healthcare. We'll have the details afterwards. The next project is AI-based food classification. Very interesting project. I'm very curious to see the outcome of this project, because this will perhaps dictate our lifestyle in terms of what types of food we may eat and what types of food we can immediately know we are eating by AI. Let's see. Then we have the assistance and medical emergency services, an app that would provide immediate, I would say, location-based medical assistance, thereby enhancing emergency response and indeed saving lives. Then we have our expert, Dr. Nanku. He will be talking about advances in neurophysiology. It would be a cutting-edge talk, but I have a buzzword there. It would be the non-invasive brain therapies. This is very important. And I see Dr. Budon is here. So most probably comments from Dr. Budon at the end of that particular talk. So in a nutshell, as Nitin just highlighted, this seminar is not only a platform for knowledge sharing, but also an opportunity to build meaningful, I would say, connections and future endeavors. So we encourage participants to actively engage in the Q&A sessions. Thank you very much.
Thank you very much, Professor Bauron. You rightly said these projects are technology-based. I think one thing we want to highlight also is the potential commercial application of these projects. When you'll see the outcomes, you can immediately see that they have a potential market. And this is something we encourage also. We support through our intellectual property services. So try and see how these projects can actually mature and come onto the market for the benefit of society. So now I would like to invite Chairman of the Mauritius Research and Innovation Council, Dr. Anne Gatia, to please address the floor.
Professor Bauron, Executive Director of the MRIC, distinguished guests, researchers, co-chair of technical can be strategically aligned with national priorities. The MRIC was set up to ensure that innovation serves as a driver of competitiveness, inclusion, and resilience, helping Mauritius to adapt to a rapidly changing world. We are living through a period where globalization is being reshaped by technology, pandemic and climate change. AI and automation are redefining work. Data is emerging as new strategic resource. For a small island developing state, these global dynamics are both constraints and opportunities. Mauritius faces structural vulnerabilities with limited resources, yet same conditions compel us to think creatively and to innovate out of necessity. Our comparative advantage lies in our human capital and institutional maturity, qualities that allow us to become not just users, but originators of innovation. The MRIC plays a critical role in bridging research excellence, policy direction, and economic transformation. The three project findings dissemination today illustrate how local innovation can yield global relevance. As mentioned by the two previous speakers, the first project employs augmented and virtual reality to make healthy living engaging and accessible, promoting active lifestyle and mental well-being. The second one harnesses deep learning to promote better nutrition and combat non-communicable diseases. And the third one demonstrates how digital technology can provide timely and equitable access to emergency medical support across the island. So these initiatives show that MRIC stand for research that respond to societal needs. They also affirm that innovation in health is not only a scientific pursuit, but also a social commitment. Looking forward, our upcoming priorities at the MRIC is first, integrating research into national policy so that evidence-informed decision in health, education, and digital economy. Second, encourage commercialization and startup, ensuring that prototypes move to the market through robust innovation and support schemes. Third, strengthening international partnership to connect Mauritian researchers with innovation ecosystem. Fourth, building an innovative culture among youth, fostering curiosity, creativity, and problem solving from early education. And fifth, leveraging innovation for resilience, particularly in food security, climate adaptation, and public health. So the RRIC is therefore deepening partnership across government, academia, industry, while maintaining strong principle of good governance and accountability. Good support. So we reaffirm our collective vision to make Mauritius a regional pole of creativity, scientific excellence, and innovation. A nation that not only participates in globalization, but shape it through the powers of ideas. Thank you for your attention.
Thank you very much, Dr. Angatia. So we'll now proceed with the presentations. So the first presentation is by Dr. Lalu. I believe it's also with Dr. Sanalu. You'll be doing it alone, okay? So Dr. Lalu is Senior Lecturer at the Department of Creative Arts, Film and Media Technologies, School of Innovative Technologies and Engineering at the University of Technology, Mauritius. Dr. Lalu, the floor is yours.
Thank you. Good afternoon, everyone. Like mentioned, I'm Dr. Lalu, Senior Lecturer from the University of Technology, Mauritius. And it's my pleasure to present our research project titled Immersive Technologies to Improve Health and Wellness. This project was developed under the MRIC Innovation Boost Grant in collaboration with Dr. Mohamed Sami Sanalu from the University of Technology, Mauritius, supported by our research assistant, Mr. Vixi Gomidanan Ritlal and Ms. Nitusha Agina, and our industry partner, Mr. Irshad Komali from the DFOS. Our work explores how immersive technologies such as augmented reality and virtual reality can help improve both physical and mental well-being. According to the World Health Organization, physical inactivity is one of the leading risk factors for global mortality. Despite growing awareness, many young people and working adults still spend long hours sitting or using screens, resulting in health complications such as obesity, fatigue, and poor posture. In Mauritius, it is noted, as noted in the National Roadmap for Research and Innovation 2023-2027, the situation is compounded by lack of regular physical exercise, limited engagement in sports as leisure, and low nutrition awareness. To this challenge, we added another crucial but often overlooked factor. Sleep is increasingly recognized as the third pillar of health alongside nutrition and physical activity. The Lancet Regional Health Europe 2023 highlights that poor sleep has become a serious public health issue, contributing to chronic diseases, reduced cognitive performance, and poor emotional regulation. It calls for urgent public sensitization on sleep hygiene, arguing that good sleep should be treated as a health priority equal to diet and exercise. This insight strongly guided our decision to integrate sleep sensitization into our project's focus areas. We asked ourselves a simple question: can technology motivate people to move more, relax better, and live healthier? Our research is grounded in a simple but powerful idea. Health is not only about movement and nutrition, it is about recovery and rest. Sleep deprivation affects productivity, focus, and emotional balance, particularly among university staff and students who often work long hours. By combining immersive technologies with health education, we sought to transform passive awareness into interactive engagement, motivating individuals to adopt healthier habits through experience rather than instruction. This project was structured about 4 objectives. The first one being to develop immersive AR storytelling to raise awareness on the importance of sleep. The second one, to design immersive exogames that encourages physical and mental well-being, to compare technology-driven and field-driven physical activities, and also to explore VR-based workplace collaboration that promotes less sedentary behavior. Together, these objectives blend awareness with action, helping users understand wellness and then practice it. We adopted an interdisciplinary approach, combining expertise from design, computer science, education, and health. We came up with 4 prototypes. We're going to present the prototypes. 2 prototypes are based on immersive AR augmented reality experience, and 2 other are based on virtual reality VR experience. For the AR experience, we're going to present 1 prototype on immersive storytelling and 1 on an immersive AR game to promote physical activities. All the prototypes followed structured processes and including brainstorming, concept development, storyboarding, character design, prototyping, testing, feedback. We are going to showcase the processes of the first prototype, the different stages of included in the development. We had the brainstorming, story scripting, storyboarding, the character design development, the prototype development, the different ideation, how we came with our characters. And for each of those, we gathered feedbacks. Based on the different feedbacks, so we worked on the final character, the vectorization of the characters, and the development of the visual narratives, the collaterals. And for the AR storytelling, we came up with different collaterals, including interactive booklet, animated posters, QR code posters, and the AR ambassador experience. For this AR storytelling, how it operates, the strategy for this one, the user, with the help of a digital device, they can point to the different printed developed collaterals, and they get videos, audios, engaging overlay experiences. And they can, on their digital device, can tap to see animation, hear stories, view short clips. For the AR ambassador experience that we mentioned, parents can they can point their digital device towards their kids, for example, and they have an AR health, like they can be part of an ambassador scheme where they can have an AR character superposed on the pictures, and they can share it through social media. For the immersive storytelling, we gathered experiences from different participants, including youngsters, parents, carers, educators, healthcare. And for those experiences, we got positive feedbacks, especially for these are the early feedbacks that we got. It showed that people were enthusiastic, enjoyed the experiences. The younger audience were particularly happy about the AR ambassador experience and were keen to sleep early only to be part of that experience. Parents, carers, educators, they found the materials as support for them to use to strengthen their message, given that they are interactive. Now, for the second AR experience, this one, it addressed physical activity. We designed an AR exo game, whereby this is a combination of gaming and exercising. Players use their phone to locate and interact with virtual objects. What we did was, at the university, the first one on the left is the campus of the UTM. The plan that we have in the middle, this is not the actual plan. We took one on the internet only to showcase how the experience worked. We anchored virtual objects in different locations on the campus. And then with the help of your phone, you should walk and only with your phone, you will see those objects. And this, you need to collect each item. You need to walk, reach, explore. And in short, the game transformed the campus walkways into a wellness playground, whereby we encourages staff students to walk around and to get the different anchored objects that we had. And how it becomes a gaming experience, they could collect like alphabets, and then they make a word, and then they win the game. This exo game, it as well motivated staff and students to take short active breaks during their day. The participants, they reported feeling re-energized, less mentally fatigued even after a few minutes of play. And this one, the experience showed how immersive technology can make movement enjoyable again without formal workouts and gym sessions. And for this one, the participants that, the number of participants that we initially targeted and the amounts that we got, we already analyzed the effect, how people visualized it. And the complete experience app is currently being refined and is expected to be deployed for a larger set of participants. This is our second prototype. Next, we explored a bit more on virtual reality as a way to combat sedentary habits. In this prototype, we have two prototypes that we developed under this one. We have the first one is on the university campus. We verified the different areas, for example, the volleyball field, the football field, the basketball field, the place where people can have their physical activities. And then we see how we could take those physical places into a virtual environment. And with the help of a headset, people, students, staff could access those same facilities that they have here. And this one, it was to encourage physical activity, reduce sedentary behavior on campus, and as well make it more accessible, even during when you have rain or the sun. And the place where our university is located, the lack of resources, it makes it like more people can access those facilities. For this one, we still need, it's still a prototype, we need to extend it for multiplayer experience, whereby we can have different people playing. For example, those games, you need to have different people together. And finally, we had another prototype that we developed. This one is focused on mental wellness. Here, what we have is we have a virtual environment where we immerse participants in a peaceful virtual environment with natural sounds, flowing water, and soft landscapes. And they were required to walk around, collect virtual puzzle pieces, assemble them. And the space that were required for this one was 3 meters by 7 meters or 9 meters. This is the minimum. We took the university conference room, and there, to create the realism, we use fans and mist sprays to give the sensation of wind and water sensation, and to give a multi-sensory experience. This short virtual walk, it served as a stress-relieving break from the work routines, and it demonstrated how immersive media can truly refresh the mind. And For this one, this is the visuals that we have here give an idea of the environment that though you are at the workplace, for 15 minutes, 10 minutes, you can have a break and be in that environment, feel the nature around. And even for the playground that we showed, we even translated it, we can have gardens whereby during the lunch time, staff can go 10 minutes, 5 minutes. Our observation, based on our observation, we saw that staff during their lunch, most of them, they sit at their desk. Some of them, they have their lunch in their cars, or they sit under the trees that we have. We don't have a lot of space at the university where we are right now. And for this experiment, we initially needed, like, we were targeting 60 participants, 30 students, 30 staff. But the preparation of this experiment, the virtual reality one, it needed a lot of preparation. And you have the pre-intervention, the post-intervention for us to see the effect that it brings. And also we needed to evaluate, for example, here we see we needed to check the inclusion factor, the exclusion factor, whether the participant whether they are fit for it. And we needed to check for diseases, motion sickness, and prepare them mentally for that experience. For this one, we are still checking. For one participant, we need approximately 6 weeks to check, like, the pre-intervention, before the intervention, the mental, the physical well-being of that participant, and then based after 6 weeks, the mental well-being of the participant. And this is ongoing, this project. To consolidate our findings, we have developed 4 working papers. One is on interactive storytelling and augmented reality, a comic-based approach for sleep and wellness education. The second is design and evaluation of an augmented reality game for physical activity and well-being in university campuses. The third one is exploring virtual reality as a tool for physical activity and mental wellness. It is a study on students and staff. And the fourth one is a virtual reality for safe and less sedentary workplace collaboration. This one is a book chapter whereby we're checking whether we can have meetings instead of people attending meeting, sitting in a room waiting for the meeting to start. They can be playing a basketball and then they wait for the meeting to start. This is the fourth one. And our future direction is threefold. We want to expand the experience into multiplayer collaborative formats with more audiences, integrate AI and IoT to personalize wellness feedback, extends the pilots to schools, officers, community health program, and the ultimate goal is a comprehensive, immersive wellness platform that encourages active and mindful living for everyone. We sincerely thank the Mauritius Research and Innovation Council, the MRIC, for funding and guidance, the University of Technology Mauritius for institutional support, and our industry partner, the Dayforce, for technical collaboration. We also thank every staff, student, and volunteers for their times and enthusiasm in the experiment. To conclude, our research shows that technology can do more than entertain or automate. It can help motivate and connect us to healthier lifestyles. Through immersive storytelling and exogames, we have demonstrated how digital experiences can encourage real-world wellness. As we move forward, let us remember, technology that heals through experience is technology that truly serves humanity. Thank you.
Thank you very much, Dr. Lalu. I think we can keep a few minutes for any burning questions that you might want to ask the presenter. Yes, please.
Your idea is very good. I really appreciate. As an inventor, I can see that things is very good. One thing is when you talk about the health and wellness of the children, so according to NIH, the screen times of the children keeps on increasing. So this screen times is again when you are going to the bed, the cosmic story is that create any health issues to the problems, especially the age which is 5 to 17 years. The screen time is more reduced. People are struggling to reduce the time of a screen timing. It will increase the screen timing, right? So how this innovation is going to tackle those issues? That is my question. Rest everything is fine. Thank you. Yeah.
Thanks very much for that very keen, I would say, interpretation of what you said. It's true that we are having an issue with the people spending so much time in front of the screen, and that's really true. The next step would be, did you try to integrate anything in there? Because we also like the kids or adults to make the amount of steps as recommended by the World Health. Is there anything that you have induced in the apps that would give us a hint whether they have moved more or not? Because this already exists in our smartphone. And the second issue has nothing to do with the sports, has to do with the eyes. I believe that we are already having lots of problems with the kids sticking their eyes not far enough, that we're going to be having ophthalmological problems. Is there any hints that you're putting in those apps that it could be done maybe not really on a smartphone, but on something larger?
Thank you. Very good question. In fact, the experience that we developed for kids was the immersive storytelling, right? And I agree with you that it uses screen time. Then what we observe is we agree or we do not agree is kids they have screen times. They are using screens, but whether if we try to replace, I don't say what they are watching now is not good, but we make it healthy screen time. Like even the experience that we have shown immersive storytelling, it can be, for example, on the box of cereals that they are eating, to encourage them to eat, for example, vegetables, cereals, all this. The parents can only point it to the box, and then they see a character, they see their character with it engaging. And then this will sort of give a motivation. And the ambassador experience that we mentioned is the parent will point it to their kids, and the parents will see it, and then take a photos and then share it. This creates a sense of achievement for the kids. In terms of the screen time for the carer, for the teacher, they use it like to showcase, for example, you are sitting with your child in a dispensary. You have different posters. We show animated posters. Those posters, they are not only static posters. They are posters that you can have a character pop out. You can have animation on the posters. And then the parent can just, instead of passively sitting in a dispensary, for example, they can show, and then the kids are watching it, something like this. And then the next step is to come up with a fidelity code. This only one code, and you can have a lot of different experiences. For the immersive storytelling, yes, the different experiences, they use digital devices. It may not be restricted to the mobile phone. It can be, if we want larger screen, to a tablet or this. But in short, it is experiences that you viewed across digital devices. The other experience, for example, VR, there is an age allowed, start age for people to use the VR. Those experiences were meant for adults to break the sedentary lifestyle and to make them walk. If I have answered your question. Thank you.
Okay. Thank you. Thank you very much, Dr. Lalu. So I see we are still keeping on time. We'll move on to the next presentation from Dr. Sadal, which is on food classification and recommendation system based on AI to promote healthy dieting in Mauritius. Dr. Sadal is senior lecturer and head of department at the Department of Business Informatics and Software Engineering, School of Innovative Technologies and Engineering at the University of Technology, Mauritius. So Dr. Sadal, the floor is yours.
Thank you, Dr. Gopal. Good evening, everyone. Good afternoon, everyone. First of all, my apologies. It's true. It's it's an This is a team, Sarvesh and Mithila are here. They were interns on the project. We are from the University of Technology, as already mentioned. Just a few quick figures about the World Health Organization with regards to NCDs, non-communicable diseases. In 2021, NCDs were responsible for around 75% of death globally, mainly distributed along heart-related problems, which is around 80 million, 2021, right? Cancer, I couldn't find all different colors. This is not necessarily breast cancer. I know it's October month, but cancer in general, around 10 million, respiratory problems, sorry, around 4 millions, and above 2 millions for diabetes. The World Health Organization again mentions that tobacco usage, physical inactivity, harmful use of alcohol, and unhealthy diets, including air pollution, all increase the risk of dying from NCDs. And a little bit more frightening, 73% of death occurs in low and middle income countries, and Mauritius is a middle income country. Although this classification, we are in 2023, we were in the upper middle class, but these figures are what matters here. In 2021, the NCD survey in Mauritius by the World Health Organization mentions that we are around 20% diabetes here in the population, type 2. Hypertension is around 27%. Obesity and overweight is a little bit more of concern, 36%, and high cholesterol around 34%. If we look at the health statistics report of 2022, this is just a line that I've drawn. It hasn't been drawn mathematically, but we can see the increasing trend. Death per 100,000 inhabitants related to NCDs. This also has an impact on our system, on our health system. From the same report, you can see that patients attending public hospitals or clinics or centers with regards to NCDs amount to around 100,000, which is number 3. Number 1 being orthopedics, number 2 being cardiology. So there is a pressure on the system based on, NCDs. So what we had as an idea was to have a mobile app that actually bundles that aspect of healthy dieting, and again, based on I mentioned that earlier, unhealthy diets, which is also related to the increase in NCDs. So we wanted to tackle that part using a mobile application. Of course, we are targeting here anyone interested in healthy dieting, but more specifically people suffering from NCDs, obesity, or overweight. What we wanted to do is, the initial idea was to have a mobile app whereby we could just, click a photo of the dish of what we want to eat, right? And this mobile app could actually give us a recommendation whether it is healthy or not healthy, right? However, to do this, the traditional programming techniques alone would not have sufficed. Working with images is very tricky, actually. I don't want to go into the details, but an image is divided into a series of small dots called pixels. And the same image with different lighting conditions, the same image of a dish with a fork on the left or the fork on the right would mean that all these values would be different. So if we had to code this programmatically, it would have been virtually impossible. This is why we switched to using a deep learning approach that supplements actually the traditional programming approach to kind of solve this problem there. Machine learning is a subset of artificial intelligence. It's the ability for machines to kind of reason without being specifically programmed. So we're not telling them, if this is happening, do that. No, they kind of learn, certain patterns, and based on that, they react. And what we've used is deep learning, which is more advanced machine learning techniques. Right. So the scope of the project is mostly on the technical aspect. Also, of course, we tried the recommendation, but going for the recommendation would mean that we need a larger team, people outside the computer science department and like that. Right. Our initial approach, this is what we set out to do, of course, to create a food database of the local cuisine. There are some specificities there. Of course, we've been doing that. Assess the different deep learning techniques that could, of course, look at those patterns and find out what, you know, what's in there. Obviously, this is where usually we spend a lot of time experimenting with different deep learning or machine learning techniques and eventually prototyping this into a mobile app. However, we came across a challenge. We've been quite far into collecting images, training machine learning or deep learning algorithms, but we realized that dish level classification, that is the prediction here, saying that this is a burger, is interesting. It's good to have, you know, a mobile app or a machine learning algorithm telling you that this is a burger, this is biryani, this is boulangerie. You get the point. But how about the nutritional content? What's in there? That was a big challenge. We realized that, you know, if we don't solve this challenge, there were a lot of challenges, but that was the main one. If we don't solve this challenge, then we might not be able to have a system that could give recommendations, right? So what we wanted to do is this. We want the deep learning algorithm or the AI or the model, for the sake of this presentation, we say it's the same thing, right? To actually classify, I mean identify that there is bread there, a piece of tomato, onion, chicken, lettuce. And this increases the expressivity of the model. That is, it can give those fine-grained level of details. Then it makes sense from a nutritional perspective, right? So we set out to do this. We paused what we were doing because, again, the second part here, the dish level classification, we've reached quite far into this. But we paused and we moved and we tackled this challenge. So that challenge basically implies that we had to use a segmentation-based approach, that is segmenting the dish, right, into different parts, different elements, different ingredients, if you want. And this, of course, had to be done at a pixel level. That is, every image has a small dot which represents a pixel. So just to put things into context, what is a standard classification, machine learning or deep learning approach? Basically, if you want to do dish level classification, what we do is this. We collect images and we group them. We classify them. Like these images, of course, we need much more images, would be labeled or classified as pizza. And then this one would be labeled or classified as seafood. Same for rice, for example, and whatever other images that we, So we classify them, we label them, and then we feed them into an appropriate deep learning algorithm, and we start the training. It's up to this deep learning algorithm to find out patterns into what basically, right, contributes into identifying a meal as a pizza or seafood or and so on and so forth, right? Once we are done, of course, you have a deep learning model, and then we can use that deep learning model. This is iterative. This is where we spend our sleepless nights. And eventually, when we are happy with the model, you know, the level of accuracy or the error has been reduced, then of course we use the model, we deploy the model. So eventually we can give it, you know, any other image, obviously, as in based on what it has learned, right? And it should be able to predict that this is pizza. Now this is dish level classification, right? So what we set out to do was segmentation, a completely different approach here, right? We still have a source image, but we had to create the mask. We had to delimit every single ingredient or nutritional element, or rather ingredient, in that dish. So we had to build that mask there. Same thing for the other image and every image that we have, right? And of course, this goes again in a deep learning algorithm. The training starts, so it tries to find out how to do these contours, how to create those masks on a given dish image. And obviously, we have a model. Once we're happy, we deploy the model. And once we get the model, obviously, we can give it. We work in black and white. That's why it's black and white. Although I've included a few masks in colors in later slides, right? So we can give it the photo of a dish, and obviously the model would, you know, predict the masks, the contours, right? We started with 7,000 images, around 7,000 images, which were already labeled from a pixel level. By the mask is the group of pixels, right? We used a set of different augmentation techniques, or if you want, customization techniques, and we increased our data set to 112,000 images. Our best model, we conducted quite a large number of experiments on different deep learning models, deep learning algorithms there. For the best one, it took over 720 hours of training, tuning, and of course, validation, just to give you an idea of the training part. And yes, after more than 720 hours of training, we realized that predicting segment masks only is not enough, right? We still need to find out what basically constitutes those masks, right? So how we did that, because we had to, just to give you an aperture of how where we were and how we moved into segmentation. So for classification, we're talking about dish level classification. There are a series of data sets which are already there. Images classified into different categories, pizza, etc., etc. As far as I recall, we have them since perhaps 2012, they were there, right? Some of them are appropriate, others are not appropriate. We started our data collection, of course. We've reached around 7,000 images into different categories, but this is where we posed this collection and this classification, because we had to move on to segmentation, right? So instead of using our own data set for segmentation, we went and explored what was out there, what were other researchers doing, and we came across these, actually the 4 of them, one is not available, the only free segmentation data sets which we could use, that is the image and the different masks. And the one which is most appropriate to our context was the FoodSeg 103, around 47,000 masks. And this is what we use. This is the one that contains 7,000 images, but eventually we augmented that to 112 images, right? So coming back, this is our solution then finally. So we've created a hybrid approach. We have to look at the green dotted lines there. So we have a segmentation model here, and we have a classification model. So what happened is that when the image of a dish goes into our first model, it's actually segmented. So we have all those masks which are predicted. And then those masks, those different masks, goes into our second machine or deep learning model, which is going to actually classify what's in each and every mask, which ingredient is there, whether it's chicken, tomato, etc., right? We were able to work with 89 classes here. So we could, so far, we can actually predict 89 classes, categories or classes of ingredients, right? The segmentation results from a visual perspective, right? A traditional biryani, which is there, again, local context. You can see the mask that has been predicted, and then we did an overlay so that we can see, whether the mask is correct or not. You'll find out that there's a small false positive there. This is, if I may just move there. Yeah, so this piece of chicken was actually, segmented as the potato, right? You should not look at the numbers. I've done that randomly in order of things that I like to eat, actually. No, not really. It just came out like that. So a second one, again, from a traditional, rather local perspective. So quite a few segments there. We were sad that we didn't have, the coconut chutney in our class, right? That is, we could not predict that, but still, it was segmented. We're not talking about prediction. We're still segmentation here. Again, you can see that the model is doing fine. I'm going to show you the figures in the next slide, right? This was pretty easy for the model. It's already kind of segmented. The traditional gâteau piment bread, right? Not bad again. The model could actually segment the bread in blue and gâteau piment, right, in the other color. The traditional ramen or boiled noodle, right? Again, not bad. The green vegetables, the meat or chicken, and then the noodles were also segmented, right? We're talking about the segments, that first model, which identify those different masks, which predicts those different masks. And the bread here, what I like about this image is that the fine grain details are actually being segmented to a certain extent. That, which I assume is a chili there, has been segmented there. So, you know, we can still segment those fine grain level of details. Unfortunately, you probably didn't see it. It took me some time to notice that. That part of the bread, which was white there, is same as the background, right? And, you know, if it took us some time to see it, we give some credit to the model there, right? It was not detected, but it's not a big problem as such, right? So that was for the segmentation. And in figures, well, before we talk about the figures, so what we've used, some technical key terms here as model. For the segmentation first on the left, it's based on an encoder-decoder system. It's a computer vision model, which is based on deep learning, right? We modified the encoder there, and we tried these different machine learning models, right? It's just a few of them. We've tried quite an extensive list of different models that could fit in there and give us the best results. The Convenext X large, complicated name. You don't have to worry about it too much. It gave us mean IOU. Mean IOU is the metrics that we use for measurement, right? So the mean intersection of a union, again, I don't want to be technical here, but I'd be glad to answer any question on this, which came around 42%, 41.9% into segmenting, right? From the literature, the best performing segmentation model was 48.7% in the same context, right? We're still lagging behind, but when we plug in this segmentation model with our classification model, the hybrid approach, we get an interesting set of results. So what we've used as classification is a traditional, again, computer vision-based model. We call them CNN. We tried, again, a few different CNNs. And again, the same model, but from a classification perspective, came out as the best model. And the top one accuracy here is around 96.9%, around 97%, into classifying each and every segment. This is the top one accuracy that is giving the best result out. Now, if we look at the group top 5 predictions for each segment, 99.7%. However, we had to compare like with like, so we compared the top one accuracy with other results that we've noted from the literature. From a local perspective, we've noted one paper which didn't use segmentation, but only classification, which was around 95%. So we still have a better result. From a global perspective, by global, we mean a data set which was used from a global context, not any particular context. Like some data sets are, you know, based on India, others on Singapore, others on Malaysia, based on the type of cuisine that we have there. So this is what I mean by global is 94.4%, and we're still doing better there. One point I would like to mention here, whenever we at the lab, as researchers, when we see results which are 99% accurate, that it rings a bell for us. There are certain things that we need to check, right? So if a model is 99% accurate, we have to look back from the data set. Was all possible cases considered? Was all possible images available? If not, then this 99% accuracy is not a good sign, right? So it has learned from a restricted set of images, right? And when you think about it, whether we can get all images, it's pretty much, you know, I won't say impossible, but very difficult, right? So that is why we haven't considered here from the literature models which are predicting 99 point, you know, whatever percent, right? Top one accuracy. So that will be in terms of the performance of our model. And of course, we wanted to deploy that. We want to make this accessible. So what we did is we built a mobile application, right? The mobile application, yes, of course, would take a photo of a dish, of a meal, right? That photo would be sent to our segmentation model, which is on the web, which is on a web server. It's not on the mobile phone. And of course, what it does here, it's going to, the image goes there, the segments come back, those different masks, right? What's in the dish. And from there, we've deployed the classification model inside the mobile app. So the classification model, we classify the segments, what type of ingredient is there rice, chicken, or whatever, right? And once done, we've integrated 2 third-party services. We've used the logmeal API so that when we send those predicted ingredients and their images to the logmeal API, it returns their nutritional value, right? And from there, we went a bit further. Again, we didn't have time to contact other different, teams from the nutritional, yeah. I think it's not, yeah. Is it okay? Thank you. Right. So what we did is we integrated also the Google Gemini API. Gemini, I'm assuming everybody has used it. It's, how do you say that? A competitor of ChatGPT, right? If you've not used it, you should give it a try. So we've integrated it inside the app. Of course, the user does not see any of these, right? What the user is seeing is, this is a screenshot of part of the application. That was the photo which was taken, again, in the local context. This is what was predicted as ingredients after the segmentation. And you can see the nutritional value, which comes from the third party there. And of course, the recommendation. We need to point out that we haven't done, we haven't tested completely the nutritional part and the recommendations. We've integrated this just to ensure that, for the sake of completeness, to show that we can use those third-party tools for recommendation. But we believe that, if we can get these values at the start, that it's quite complex anyway. And this is where we need the team to be multidisciplinary at some point in time, right? So if we can get those nutritional values, if we can, associate them with what we already have, it will be more appropriate for the app or for the system to do it, right? So this is where we are. Yes, so basically our segmentation model is not too far from the state of the art in the literature, but there is room for improvement there because I pointed out, we were talking about 700 and more than 720 hours of training configuration. We'd put it overnight and then, wake up the other day and look at the results. And then, you'll find out that it bugged, it stopped at some point in time when we were sleeping because, something which was wrongly coded, right? So what I'm trying to say is that it takes time to get these, to train these model. And something which is mentioned on the other slide, the number of parameters that we had to train for that convex model is above 350 million parameters. Why? Again, because we have to work with images. If we take an image, which is 10 by 10, very small, we can't work with that. 10 by 10 pixels. It has 100 pixels. A colored image appears in red, green, and blue. So 100 multiplied by 3, right? We cannot even, as human beings, it's very difficult for us to work with 100 by 100, right? Now, imagine 1,000 by 1,000 pixels, right? You multiply that, you multiply by 3. That would be the number of pixels in one image, right? And we would have, all these pixels would have to go in the parameters of the model, right? And that would be for one image. And we've worked with 112,000 images. This is what, this is what creates this, increases this whole training time and the rest. So, however, when we plugged in our segmentation model, because see, from a technical perspective, that segmented model, the first part, we could have stopped there. But we wanted a better accuracy into classifying the different ingredients. So that's why we went for a second model and a hybrid solution, right? So when we plugged in that hybrid segmentation model with the classification model, the second one, we have a high accuracy hybrid model, which is around 97%. And of course, we've been able to create this prototype, the application, the team is there. I think one of you have it on your mobile phone. Anyway, we have a video if that's necessary. We can play the video. It's there. It's on a mobile phone. It's working, right? That would be in terms of the different achievements, and of course the future works. So we still want to work on that segmentation, but it does make sense, of course, in this particular context, but you'll find out it makes sense in every different other context if we can have an artificial intelligence model that can segment, an image into its different elements, right? Of course, we want to extend, and this we're already doing it because we had to pause our data collection. We were doing data collection for prediction at dish level, so we had to pause that and move to segmentation. So of course we want to extend, and this is something I'm pretty sure we're going to, complete in a given lapse of time, right? It's not a technical thing. It's just, we have to do it manually. We have to create the mask for every image that we have collected in our local context, right? So we're going to do that. And of course, as mentioned earlier, if we can plug in nutritional information with the image that we already have, right? To a certain extent, of course, that would be interesting. Something which I didn't mention, we also wanted to tackle volume in an image, right? But we realized that in that short lapse of time, we had so many technical challenges that we couldn't tackle volume, right? Which is, another project in itself, right? But volume with nutrition, nutritional value would again be a little bit more interesting, right? So that would be it. Thank you very much. I would like to, of course, thank the MRIC for their support, right, throughout the project, the University of Technology Mauritius, and of course, everyone who collaborated on the projects, including the two interns, our interns who are here. Thank you very much, ladies and gentlemen.
Thank you very much, Dr. Sadal. We have time for maybe one question. Anyone? Yes, please.
It's a very good project. When we are working for one of the project, know your food. The same thing, we have faced a lot of challenges. Then we trying to figure it out, measuring the plate. The plate will be the common for everywhere. So when we are identifying right now in the local foods, we all start measuring the plates, all the plates and the bowls, then occupying the space and the length of the food. Then the segmentation will be more easier, sir. Thank you very much.
Thank you very much. I just want to comment on that before the next question. We thought of doing that. Please go ahead then. Yeah, go ahead. Yeah, sure.
Allow you to answer the question.
Sure.
When we finding the nutrition value,
It's okay.
I got it from the people. You are saying this food nutrition value, this is a thing. Whether this is gluten-free, how the nutrition value will be matched. It is non-gluten and it is an organic or inorganic.
Yes.
So I face a lot of issue on this thing. Thank you. I like to share.
This is why I said we had a lot of challenges.
Congratulations, anyhow. Bon courage in your way of climbing the Himalaya.
It is.
Excellent. I'm a
Thank you,
physician
yeah.
in nutrition. We've been trying to tackle the problem. Knowing that obesity comes only on a differential of 500 calories per day in excess. You
Really?
eat a Big Mac or a rounder in excess every day, you're going to grow obese. So it's very interesting what you're trying to do. It's a huge challenge. The question was, how would you manage? Because we in Mauritius, we like to eat everything in the plate, all in one, we said. According to what I saw in the images, you try to segment the food by putting each and every one, bread, jiri, curry, lentilles. You've tried to separate them. But here we have, as we say in La Réunion, jiri en bakari. So the question is, how are you going to tackle, because this is the major issue. Otherwise, the image is going to be confounded with rice, and you have the meat under the rice. Is that an issue for you? And the second thing is, how much, and I mean, the data collection, how much powerful your system has to be able to challenge and get the results?
Yes. Along the same line? No, can I answer this one? These two first? Yes, thank you. The measurement of the plate and the bowls, they are laughing, right? The team there, we sat and we said, how are we going to do that? We wanted to do that. But then we also realized that we have to come to an average. But the bowls at my place are not, the plates at my place are not the same at their place. It's what we were talking about. No, see, it does make sense. But if you average it out, it solves that problem of volume. because you see, you have a min bui, you have this, boiled noodle. But if the bowl is like that and, the bowl is like that, or it's on a plate, the volume is different. So nutritional element, it's.
We had a huge problem greater than Arabia. You get the scale because pure scale, they provided the phones, readers, to give you a scale on your arm with around 3 huge amount. We can sort out the problem with the thumb of the patient. When he's eating the food, he puts his thumb by the side of the plate, and in consultation, I'm going to see his thumb.
Yes.
What's the side of the plate?
Exactly. To tackle the volume, what we wanted to do is to take 2 photos, a top and a side view, right? But we haven't been able, short of time, we couldn't do that. We were stuck with a machine learning training algorithm. You've seen that, right? Only 500 calories per day, only? 500? I need to be careful. No, I think, no, I don't eat Big Macs, but 500 calories is like, it's easy, for as an intake. Yeah, no, good to know. Thank you very much. We have to talk after.
Hi,
Yes, sorry.
Stay, quick question.
yeah, I just want to from perspective of being in innovation, so well done with what you're doing as an academic and working on the model, etc. So if we want to get to the outcome of information for classification, what I wanted to say is why don't we build also on what other people has been doing? Because it's very difficult to compete on an AI application where there are many food classification AI apps. You can have Calorie Mama, Log Meal, and which is very, very advanced. So suggestion would be rather create data that feeds into these models that exist rather than to try to invent a model or build a model. And also maybe have you looked at using pre-trained models in food classification that exist already rather than building everything from scratch? So for me, the machine behind is already invented. It's about the data that we need to topical to our country, which needs to be fed to these models. So I'm saying it would be focused, not be have the data, feed the data to existing models rather than building models and using local data.
The model that we use are transfer learning models. I probably haven't I don't know if I mentioned that term. So they are pre-trained models, which we wanted to train in a local context, right? For the segmentation part. The classification part, I think this one we trained from scratch. Yes, this one we trained because that was just about, identifying, right? But we've used a transfer learning approach with a pre-trained model to come up with the segmentation part, definitely. And you're right there. It's not about, as we say in computer sciences for engineering, it's not about reinventing the wheel, right? So we build on top of what's already there. Yes.
Okay, thank you. So just before you go, we've got also some people who are listening to us online. I'll just take one of the questions that's come. If you can have a quick answer so that we'll move on. So how did you ensure validity of the generated nutritional values, taking into account hidden ingredients such as added oil and added sugar?
Yeah, unfortunately, like I said, we haven't tackled this part. We used that third party, which was a log meal API, to give that nutritional aspect. We were really focusing on the technical machine learning aspect. And we didn't tackle that part. And we haven't done extensive testing whether log meal is doing it right or not, but we just wanted to show that for the sake of completeness that yes, this can come into there. Yeah, I don't know. I hope that answers the question.
Okay.
Yes, so thank you very much again.
So thank you again, Dr. Sadal. We'll now move on to the next presentation, Assistance and Medical Emergency Services by Mr. Lal Singh, who's lead auditor at Tech Apps Limited.
Thank you, everyone. Professor Bauran, Executive Director at MOIC, Dr. Angatia, Chairperson of MOIC. Members of MOIC, esteemed guests and colleagues, good afternoon. So my name is Vikash Lal Singh. I'm representing Tech Apps, which is a tech startup, actually. So we develop applications that try to solve everyday problems. And today I'm going to talk about AIMS. I mean, we've tagged it as AIMS. It's Assistance for Medical Emergency Services. So if you look at, so that's the idea. If you look at medical and emergency services in Mauritius, so it's a huge cost to our public services and also in private sector as well. It's a very big cost. So I don't know about you, but I had the unfortunate experience to come across people who had the need for emergency services. For instance, I'll tell you a story which I came across. I was traveling one day, I was driving around roundabout in the north. I saw an elderly gentleman who was riding his motorcycle. He just was lying on the side road. I came in, I just stopped my car nearby. I tried to provide him assistance, and he was apparently having an attack. I don't know if it was epilepsy attack or cardiac arrest. I don't know. He was having an attack. And I tried to call SAMU on 114. And they told me that all the ambulances were already taken up for other patients. Some of them were even commuting patients to do dialysis and all these kind of things, and they couldn't allocate someone to help this guy. Some other people stopped by. We tried to bring help to the elderly person, but none of us were medical experts, right? So all we were trying to do was trying to get some real medical assistance. And it happened that a private clinic, which is nearby, the ambulance was passing by, and some volunteers would try to stop it. And he says, no, I'm from private clinic, so we cannot take on board patients unless patients are like going to be covered. The cost was going to be covered, but this was just any member of the public. At the end, after like a few minutes of negotiation, we managed to convince the ambulance driver to take the person, the elderly person, and bring him to the clinic to get assistance, hoping that his next of kin or family would like support the cost. Why I'm telling you this story? Because 1.5 hours later, on my way back home, SAMU called me and asked me if I'm still with the guy. And because now they have an ambulance that's free, so they asked me, are you still with the person at the roundabout? We can now dispatch someone. I said, you're a bit too late. The guy might already be dead. I don't know, but because I left him there. So that gives you an idea of how difficult it is in such a small island as Mauritius to get medical advice, to get emergency services. And with traffic congestions, it's becoming even worse, actually, for ambulance to reach people. And the logistics you need to be able to serve even a small country as Mauritius in case of an accident or medical emergency is really too much to invest on. So that's where we came with the idea that we want to solve an everyday problem. We don't want to replace emergency services, but we want to bridge the gap in between the time that a person who needs a medical emergency is able to get official help by people who are available and who are medical experts. So that's the idea that came in. It's not a novelty idea. So mind you, it's something that exists in many countries, in Singapore, for instance, as well. And I'll go through the application, how it works, but also about the idea and the statistics behind on this. So during our research work, when we tried to understand the feasibility of this application, we found that around 350 people in Mauritius yearly, so that's based on 2022 figures, suffer from cardiac arrest, right? And only 5% of them actually survive this. Figures show that if these people were to get help, assistance, CPR, or medical help within a reasonable amount of time, which is less than 15 minutes, the rate of survival might increase to 15, 20% even. So that means maybe 3/4 of the people who are actually getting these, these issues, not 3/4, but maybe half of them might have survived, right? So this is alarming because these people unfortunately pass away because there was no one there to help them at the time that they got this cardiac arrest, or they were unable to call on someone, right? Because sometimes in those situations, people do have the ability to make a phone call or at least request for help within a minute or two before they can be unconscious. So that's why we thought, okay, let's look at the bigger picture. So, I mean, this is the data from 2022. We haven't refreshed it because by the time we were preparing for the project, we had that data. Probably the data is much higher now. My previous colleagues, they talk about the health data, the NCD data. So we do have more people who are unfortunately suffering from those cases, which could have helped them survive in case they had assistance and medical care on time, right? So our idea is, imagine that every people in Mauritius, everyone has a mobile phone right now. Everyone has a smartphone that has GPS, that has applications, even with elderly people. So we have a population that's growing old right now, but even the elderly people, they are very tech aware because you don't need much to be able to use a smartphone. It's touchscreen, it's very easy. Once you teach someone, it's intuitive, right? So just imagine if everyone could, from their smartphone, have an app where they can just open the app, click a button, red, amber, green, red, amber, or yellow probably, depending on the severity of the problem that they have or the assistance they need. And then someone could respond to them, an intermediate person. So a qualified health professional, whether a nurse or doctor, could, or first aider actually, could help them within the region that they are, instead of, and while waiting for like ambulance, fire services to come to help them. So that was the big idea actually. So what we've seen is in Mauritius, we have roughly 8,000 healthcare practitioners, including first aiders. And as I said, these figures date from 2022, so it could probably be higher. And at the time we were preparing for the project, that was around 800,000 cell phone users. So mostly smartphones actually. And so that means roughly a ratio of 1 to 100, meaning a healthcare professional could basically assist up to 100 people in the community, right? So we came with the idea of CFR, community first responders. I mean, when we were doing the ideation, me and my colleagues, so we came with different names, but then we found out that in Singapore, the same idea exists. So what we find out is many idea that we have is spontaneous, yes, but it might already exist. People have the same idea in different parts of the world, and they might have elaborated it differently, but basically it's the same. So then we came across what we call CFRs, community first responders, which exist in Singapore. Basically, what it is people from the community at large. So whether it's doctors, nurses, first aiders, so they register themselves on an app and they make themselves available. So this is our idea on the app, like CFRs, they make themselves available. So let's say I'm a doctor. I work from 9 to 5. After 5 to 7 p.m., I'm available to act as a CFR to provide help to the community, right? To assist people in need. So I'll put myself as available on the app, and the app will track my geolocation. And in case someone is in need of help, they just press a button, red, amber, or yellow, depending on the severity. And that dispatches a message to the CFRs within the region of the patient or the person needing help, the CFO who are within the region and the CFO who are available. Then the CFO just need to accept the request, and once they accept the request, they get the name of the person, the telephone number, the geolocation, the next of kin details for it, so they can call the family of the person while they are attending the person, and they are able to help, right? So this is what we wanted to proposed as an idea, and this is what we tested as an application. So I've talked about the different severity, red being like you cannot provide any additional information. I'm either bleeding or I have a cardiac arrest. I have really a medical emergency. I cannot talk or type. I'll just press red button. Amber would be, okay, I do have the ability to answer a few questions. So what is my emergency? Like predefined kind of questions. So are you hurt? Are you bleeding? Are you having a panic attack? Are you having a heart attack? Are you about to faint? These kind of very basic questions, like within 30 seconds, I can answer a few questions to give the CFO more context, what kind of help I need. And yellow could be an elderly person who could, let's say, need an injection to be done, but they don't have anyone available. So, okay, I need to inject myself with a medication, which I take regularly. My nurse is not available. Maybe within 4 hours, 8 hours, someone could attend to it, right? So this was the idea in terms of segregation for the different severity levels. And we wanted to be as intuitive as possible so that anyone could technically open the app gets your location, geolocation. You're already registered on the app. So you have your name, your phone number, your next of kin, your exact details. And then it's intuitive, so anyone can use it. So we use geolocalization to localize the CFRs who are within the community or nearby, so within a range of 3 to 5 kilometers. So if I'm based here and I click on red buttons, only CFRs who are marked as available within the region would get notified on their phone, on the app. And then they can, just like Uber, they can accept and attend to the request. And if no one attends, no one responds within a few minutes, then it extends to a larger region. So that's the idea. And so the CFRs themselves, they are curated list of healthcare professionals. So not anyone could register as CFR. So as a healthcare professional, I can register on the application as a CFR. And eventually it will ask me a series of questions, and then I need to validate my KYC details so that the application knows, that will need to be done manually at the back end. The application knows, the platform knows I'm a valid person who can provide assistance. And the CFO could potentially, at the same time they are attending someone in need, call emergency services. So let's say someone say, okay, I've been stabbed, I'm bleeding. And then CFO is attending. CFO can also call in police services, fire services, and by the time he reached there, he can provide him first aid, like immediate assistance, and then waiting for actual official services to come in. So as I said, the idea is not to replace emergency services, but just to be a gap, to bridge the gap between the time that emergency services come and attend to people, to increase the chance of survival and increase the rate that we can provide emergency assistance to people. So in terms of how we've designed the application, it's, as I said, very intuitive. So people can log in once they've registered their personal details, they can log in easily. So basic personal details would be name, surname, ID number, address, residential address, so that sometimes the geolocation might not work well, but at least we know the actual residential address that will be shared with the CFO that accept the request. And of course, the next of kin detail, because it's always good to know who are the contact details for the person's family with the person needing help. And these are how, this is how it works actually. So we get a series of requests from different people, and then a CFO, once they accept a request, they can get all the details, so they can actually understand in some cases, you can also put depending on how people register on that application, you can put your medical history. So people are known to have history of epilepsy, for instance. So the CFO knows, okay, I'm dealing with that type of case actually. And then they become better prepared in terms of understanding how to help, or they could call in other CFOs or other colleagues to assist them in case of, depending on the emergency. One thing is that unfortunately we didn't, I mean, not unfortunately, but that would have been the next step of the project or of the application is to, like they do in Singapore, to have AEDs apparatus with some CFRs that can resuscitate people. And that should be something that would come depending on the maturity level on how we deploy this kind of application in a country as in Mauritius. So I'm going to show you a small video on how it works. I hope it plays well. So as you can see, once you select one of the requests, you can get the direction, you get the geolocation, and then it tells you how many minutes it takes you to get there, to get to that person. And while on the way, you can potentially, the CFR can call for services like police, SAMU, and ask them to meet them at this location. So this is our proof of concept. I'd like to thank the MRIC for supporting us in developing this application. So this was a proof of concept to prove that the idea works and that it's something that could be elaborated upon and deployed actually in Mauritius. And I'll be happy to answer any questions if you have.
Any questions? It's such a vital tool. Okay, I've just got one question. The dispatch time for a CFR to reach a person in distress. I mean, the example you showed here shows still in a sort of 20-minute period.
Yeah.
Are there alternative ways to shorten that sort of response time?
Yeah, so in the test that we've done it in remote areas, right? Because I mean, the density of towns is such that within the towns. And that's why we try to test it on remote locations, on rural areas. And we found out that, yeah, typically it all depends on how many people within the community are first aiders or registered CFRs. So the idea is, one, we have registered CFRs, community first responders, for actual health professionals. But eventually, I mean, potentially that could have been an idea, is to have people trained to be CFRs. So train volunteers that could become CFRs through a certain set of training. Of course, that depends on the strategy and how we as a community, we want to help each other as well. There's a degree of willingness to help as well that comes with it. But this is what could eventually shorten the time for people to reach out to others.
What would be the concrete steps to make this a real up to use practical solution?
Yeah, so at the start, when we were discussing with the panel for this before we get funding, so we were asked this question in terms of whether we can collaborate with SAMU, with our official medical emergency services. And I think this is where we need to start with. So basically having working in hand with official like SAMU services. But under the Ministry of Health, I think that if these projects were to be driven or endorsed by the Ministry of Health, I think that would facilitate to have a national application, which is deployed freely on everyone's cell phone, enable them to have access to the CFRs and to medical assistance.
Maybe more easily access to the clinics, for instance.
Yes, so as part of the POC, we worked with a clinic to try to understand some of the medical emergencies, what kind of response time we need. And they were onboarded as well. They said that most people nowadays have healthcare insurance, and they wouldn't mind taking on board almost anyone. And then eventually the patient's family would pay for the services, or they could find an agreement. And we are also thinking about exploring the potential to work with insurance providers. So once if I were to register as a user, I can put in my insurance details, health insurance details as well. So by default, I mean, it's there, and people know I'm covered. They can also, I mean, it's easier than for clinics, like private hospitals, to take people on board. So it needs to be driven, I think, probably by the Ministry of Health in collaboration with private sectors as well, and the hospitals providers, and the actual emergency services. So it is not something that should be done in isolation, but in consortium with everyone.
Okay. So
Thank
once
you.
again, thank you very much, Mr. Latsing. Okay, so we will now move on to the final presentation. We have a presentation on advances in neurophysiology with focused ultrasound. So the presenter is Dr. Jean-François Nankou. He's based, as I said, in Canada. He's a scientific associate at the Cranville Research Institute, Toronto Western Hospital. He's also University Health Network and Sessional Faculty at the University of Guelph-Humber in Ontario, Canada. So Dr. Nankou, I hope you're online. So the floor is
Yep.
yours for your presentation.
Okay, thank you. Can you hear me okay? Hopefully you can.
Yes, we can hear you.
Yep, perfect, great.
Okay.
So thank you very much for inviting me. I'm very honored to be able to present to scientists in my country. So I'm from Mauritius, so it's really a pleasure to be here. Well, remotely, hopefully soon in person. So I will talk a little bit about focused ultrasound and sort of hopefully give you an idea of what it is, what are the advantages, a little bit about the data that we have collected so far in terms of healthy brains and clinical applications, and potentially some future directions that may be of interest to you in Mauritius. So focused ultrasound, hopefully you can see properly. Focused ultrasound is really about using ultrasonic waves to focus acoustic energy on a single spot. So if you give me a second here. So for example, in this case, you can see a transducer that will emit ultrasonic waves up to a focal point, and you can use multiple elements. So each one of those will shoot an acoustic wave and they converge on a single point. The more elements you have, the more precise you can be. What's interesting is that when you do that on the brain, it does certain things to the cell membranes. First of all, it can heat it up. So, and there are some advantages why you would want to heat up the cell membrane. It can cause cavitation. So in this case, it would damage the cell. And it can also cause some mechanical force, which will open up ion channels. And we'll go through that in a couple of slides. This is what it looks like. This is a 4-channel, so it only has 4 elements, and this is the most common type of transcranial ultrasound, and this is the one we use most often in the lab. This is just a sort of a picture with our neuronavigation tracker. So as we're stimulating, we can look on our neuronavigation system on the MRI where we're actually sonicating, where we're stimulating in the brain of a patient. So before we deal into my specific type of research, I wanted to sort of give a broad overview of focused ultrasound. So there's multiple applications to this. So focused ultrasound, when we apply to the brain, we'll call that transcranial focused ultrasound. We can use it to induce to cause heating in the brain and to destroy parts of the brain. And the reason for this is, for example, if you want to do surgery, Well, the advantage with focused ultrasound is that you can focus the beam at a very specific point in the brain. In this case, for example, you can see a very tiny spot on the thalamus. You can destroy that if there's a reason for that. And this is being used to treat movement disorders such as essential tremor, and very successfully. But the key here is that it's a incision-free surgery. So you do not need to open the brain to actually take out that piece of the brain that you need to take out. So this can be done outside. So the ultrasound array is outside the brain, and all the energy is focused on a very small point. I have to mention that this is about 3,000 elements. The one we use in non-surgical methods are about between 1 to, let's say, 100 elements. So there's quite a big difference. You can also use it to open the blood-brain barrier. So, for example, if you want medication to reach a specific part of the brain, you can use microbubbles. You inject microbubbles, and as this goes through the veins and arteries, you can shoot the ultrasound at that specific location. It opens up the blood-brain barrier, letting out the molecule at a specific location. But my talk today will focus specifically on using it as a brain stimulation method, what we call neuromodulation, and it's mostly to change how the neurons are behaving, so changing brain activity. And the reason why we want to do this is because, as already mentioned earlier, population is aging. So it's not in Mauritius, not only in Mauritius, in Canada, it's worldwide. So we are running into problems where we're going to get a lot more neurological disorders. So that's on the rise. And medication, especially oral medications, tend to be non-specific. So that's why you get a lot of side effects, and very often patients are not compliant to that because the side effects are very disruptive to them. So focused ultrasound may help, well, brain stimulation in general may help to have a more targeted interventions. And also it can induce plasticity. So it forces the brain to change certain patterns of activity. The most sort of powerful brain stimulation method that we have is called deep brain stimulation. And this is done by implanting two electrodes, usually two electrodes, deep in the brain. So this is very often done with Parkinson's patients. So we'll implant that in the area that is pathological, and we try to correct abnormal activity. I just want to show you a quick video of the effects of this method. So it's a very powerful method. So hopefully I can.
If anything feels uncomfortable, let me know.
So as you can see, this patient has a very bad tremor in his hand, and he has the electrodes implanted right now. And in a few moments, the electrodes are going to be turned on.
You feel that?
Yeah. There's a buzz in my head.
Is it gone?
Yeah.
As I increase the voltage, you sometimes get a little buzz as the voltage increases. And I can tell we haven't stopped anything with the tremor yet. Do a little bit slower. Okay, I want you to go back and forth to my finger. Back to your nose. To my finger. Back to your nose. Hold on my finger.
So as you can see, this is a very powerful method. This patient now is perfectly, seemingly normal in terms of his behavior, no tremor whatsoever. So it is quite a promising technique for certain disorders, not just Parkinson's, but it's being used in quite a lot, including depression and even eating disorders. It has been tried. One of the problem with this method, deep brain stimulation, is that it requires brain surgery, and a lot of patients might be too old or have other disorders that preclude doing surgery. So it's only about 5% of patients with Parkinson's who are able to do this surgery. And very often as well, it's not a sure way. Sometimes it doesn't work. The location is not correct. There's many issues with it. So what we do is we look at non-invasive versions of brain stimulation. So transcranial magnetic stimulation is another established method, very powerful, where you can stimulate the brain at the surface level with magnetic stimulation. And in this case, this is a method that in certain disorders like depression is very promising. In fact, it's FDA approved for depression in the States and in Canada. And it's non-invasive and it's very quick and it's painless. Other method also a little bit more cheaper method would be using applying directly electrical energy to the brain itself. It's a little bit weaker in terms of benefits, but there is indication that this can help. However, all these methods come with very big problems. So DBS, again, I mentioned surgery. With the cost of surgery, there's possibility of infections. With TMS, when you model the actual area of activation, you can see it is quite broad. And with TDCS, or sorry, the electrical stimulation, it's even worse. So there's no focus at all. So you're actually stimulating half the brain. Here, it's quite a big area, even though it seems small, but it's a big area for the brain. I want to show you now a model of the activation area for focused ultrasound. So this is the area, a very tiny spot, and this is with the 4 elements. So now you can imagine with 3,000, it gets very specific. So focused ultrasound allows us to be very targeted in terms of what we are trying to target. And it's a novel method, so there is not a lot of data out there on how it works. So we're in the process of figuring out what we can do with it. But the fact that it's so focused is very promising. So the first major study that we have done was actually to look at the effects of focused ultrasound if we targeted the primary motor cortex. The reason we did that is because we can combine it with TMS, the magnetic stimulation. So with TMS, you apply the magnetic stimulation to the motor cortex. And what happens is if you're, for example, stimulating the hand area, you get a movement. When you stimulate here, you get a movement from the hand. And you can measure the amplitude and intensity of this movement with electrodes, with surface electrodes. So this is a motor evoked potential because of the TMS. And this is a measure of excitability of the motor cortex, how readily we can get the cells to go into action potential. And also it's diagnostics. If information travels all the way without any problem, without any latencies, then the pathway is perfectly intact. So what we did was first we measure the amplitude without any stimulation, without any focused ultrasound stimulation. And then we did what we call a theta burst stimulation. So it's just a 5 hertz stimulation. And then we measured again with a TMS 30 minutes, 60 minutes, and 90 minutes after. And this is the data. This is normalized to the baseline. So when there was no focused ultrasound. And as you go, as you remeasure every time 30 minutes, 60 minutes, and so on, you do find that the amplitude of this movement has actually increased quite significantly, actually, and it stays for 90 minutes. And the stimulation of the ultrasound itself took only 120 seconds, so 2 minutes. So 2 minutes application to the motor cortex, huge spike in terms of excitability. Other studies have taken our protocol and have found that it actually, you can, when you stimulate one area, it does propagate, so it activates other areas that are functionally connected to this. So it's not, even though we're one localized area, it's powerful enough to engage the whole network. We also have done some clinical applications, and the main the earlier studies we've done have been with Parkinson's disease, where again we use this method of trying to look at the motor cortex excitability. With Parkinson's disease, that is always an issue. The excitability is very low, so the motor cortex is not responding enough, which is why you get slowness of movement in Parkinson's disease. And again, at the baseline, we normalize everything to the baseline. And here we have controls, healthy age-matched control. We have Parkinson's patient on dopamine medication, which is the regular medication. And I should point out that the medication is not a permanent fix for Parkinson's. It will lose its effectiveness eventually. So that's why we're always looking for new ways to control the symptoms. And also patients without any medication. And so we measured the baseline with TMS, then we did the ultrasound, and then we looked again at T5, so 5 minutes after 30 minutes and 60 minutes. And what we found is that, of course, the control, we found increased excitability, just like we saw with the previous slides. Patients with dopamine medication also showed this increase, but patients without medication did not. And we also found that there was an improvement in bradykinesia, which is a cardinal symptom of Parkinson's. So what this suggests is that focused ultrasound to the motor cortex might be an adjunct therapy in addition to the dopamine medication, because it seems to influence the motor cortex only when they are on levodopa. The fact that we did find clinical evidence is also very promising. And again, this is based on 120 seconds of stimulation. I am also currently just finished a study on orthostatic tremor, which is a very, very interesting disorder where patients will get a tremor in the leg if only they stand, or if they are leaning, then the tremor moves to the arm. But they don't get this tremor if they're walking. And we think this is a pathology in the cerebellum. So again, we stimulated the cerebellum bilaterally this time. So this is actual data from one of my participants. And again, we stimulated for 120 seconds. The first thing we did, looked at tremor amplitude in the legs, and this is with electromyography, so surface electrodes on the muscles. And again, we measured at baseline, and then I stimulated, and then I looked at different time points. And at 5 minutes, after 5 minutes of, so I did the 120 second stimulation, then after 5 minutes, I remeasure again. And what I find is that there was an improvement in the amplitude of a tremor in key muscles like the tibialis and the quadriceps. So these muscles seem to be reducing the tremor after 120 seconds of stimulation to the cerebellum. But what's more interesting, and actually a very strong result that I found, was in terms of the connectivity with the cerebellum and the motor cortex. So the cerebellum projects directly to, well, somewhat directly to the motor cortex. And we can test this by, first, we can stimulate the motor cortex just like I explained before, and we measure the amplitude of the MEP. However, if you stimulate with TMS, if you stimulate the cerebellum 5 milliseconds before you do this TMS, you find that the amplitude becomes small. So this suggests, this shows the inhibitory input of the cerebellum to the motor cortex. So the cerebellum reduces the motor cortex. In a lot of disorders, this can be a diagnostic tool as well, because, for example, in Parkinson's disease, so when you do TMS alone, you get the amplitude, but when you stimulate 5 milliseconds, you stimulate the cerebellum right before the motor cortex. In the healthy people, you have this inhibition that happens, but you don't get that in Parkinson's and a few disorders such as orthostatic tremor. So what I found is that after 15 minutes, again, measure baseline. So I stimulate the cerebellum, then 5 milliseconds after I stimulate the motor cortex, and I get my baseline amplitude. And then I do 120 seconds cerebellum stimulation. And then after 15 minutes, I measure again, stimulating with TMS, the cerebellum, and then the motor cortex. And what I find is in 8 out of 9 patients, this inhibition is improved. So increased inhibition in those patients. So these patients, their inhibition is pathological, so it's not as inhibited as it should be. But again, 120 milliseconds seem to correct this. And this is a single session. So before I move on, so what we're thinking here is those data that I've shown you are just one stimulation, and they're just 120 seconds. And with brain stimulation, what we do know from other methods is that to have a lasting effect, you need repeated measurements. So the next step is we're starting a few large clinical trials where patients would come in multiple days, and we'll stimulate them sometimes multiple times during the day, and to see if that improves their symptoms in the long run. So for the moment, we're looking at about a month or two after the stimulation. There are already some promising data, but this is very early days in terms of those big clinical trials. But this is our lab focuses on movement disorders, but there are a lot of studies coming out now looking at its effect on depression, pain, dementia. All these studies have found some promising evidence that focused ultrasound can be very useful. And so the amount of studies are ramping up and clinical trials are coming out very quickly. So this, I know I went through it in 20 minutes. It's kind of is a lot to talk about in 20 minutes. So I barely scratched the surface. But what I want to show you here is that this is such a novel method that we don't really know a lot about it. And the parameter space for focused ultrasound is continuous. So it's a huge problem. There's too many parameters that we don't know the ideal one. We stumbled upon one, but we don't know if it's the best stimulation. So there's always room to improve protocols. The design of the transducers themselves, the equipment themselves are very early days. So every year, new focused ultrasounds are coming out that are better, more elements. And other issues that we're dealing with, for example, is ability to maintain your ultrasound on a very specific location because it's so focused. As you're holding your transducer, a minute change in your orientation will completely miss your target or target somewhere else. So this is sort of a pitch also for those who are maybe inclined to or interested in these sort of areas that I think this could be an area where Mauritian scientists can be involved because it's such early days and it's such a promising area. And again, I've talked only about brain stimulation, but there's also the surgery aspects, which I haven't talked about. And there's room for improvement. And at the hospital in Toronto, we're always willing to take students, so exchange students. I was a student in Mauritius, so it's not that easy to find opportunities. So what I want is to open up the opportunities for students in Mauritius or for collaborations with labs in Mauritius, whether in neuroscience research, but as well in sort of more bioengineering or any improvement to the sort of hardware development itself would be great. And really, it's such a new method that there's really only a few labs in the world that are currently doing this type of research, and they're mainly located in Canada, Germany, UK, and the US. So Mauritius has potentially an opportunity here to open up as a hub for this sort of really exciting novel brain stimulation technology. And I know there's quite a lot in India, for example, where we have a lot of collaborators, India, Taiwan, South Korea, where they are really starting to do research within that space as well. So I know that was a lot, so but I tried to give you a broad overview, but I'm very happy for you to contact me if you're interested in chatting more. So these are my funders. Our main PI is Robert Chen, and he's a neurologist scientist at Toronto Western Hospital. And also our physicist, Dr. Samuel Picotto, who is in University of Calgary. And this is our team in Toronto. These are my students from University of Guelph Humber, and all my funders as well. So hopefully that was somewhat interesting and not too overwhelming. And I'm happy to take any questions you may have.
Thank you, Dr. Nanku. So the floor is open. Anyone who's got questions, please. Yes.
Congrats, Dr. Nanku, very sharp presentation. The question would be about the training of the staff. How we're going to proceed with that? The technology is coming up, I believe. And the major problem we're having in Mauritius, in fact, I'm a physician. I'm mostly working on nutrition. I'm trying to work with my colleagues on neurological disorders here. We have lots of them. And the major problem is the diagnosis. So people don't have access to a proper diagnosis. So at the end of the day, we might be treating things which are clinically not relevant to what we're supposed to be having as diagnosis. How do you curb this problem? Because you know those features in Mauritius, huh?
Yeah. So I mean, even here we do have a lot of problems where because our hospital is very specialized, so we do get a lot of misdiagnosis from more generalist neurologists, and when we find, oh, this patient does not have Parkinson's, it's completely something else that looks like Parkinson's, but is not. So this is very common. And one way that we do this is we use electrophysiology. So just like I mentioned, for example, there's certain cues that we can use with brain stimulation, just like the TMS, for example, the amplitude of a movement. TMS is actually a great tool for this. The latency of the time it takes when we stimulate the motor cortex to get to the hand, all these are clues that can be specific to certain disorders. So it does help rule out some disorders if you do implement. So TMS is, I mean, it's an expensive machine, but it's not incredibly expensive. So, and I read recently that there is one in Mauritius, but so it's a very powerful tool. You can also you can interrogate the microcircuits by doing multiple TMS back to back, depending on the timing. So you get a lot more information about what really is the pathology. Symptoms might look the same, but disruption in brain circuits, you can sort of interrogate that with a brain stimulation. So it does help. The other thing would be, of course, surface electrode, which are fairly cheap to just look at the behavior of the muscles in case of movement disorders. And yeah, so in general, trying to use all those tools. Of course, these tools help with certain disorders, but they won't necessarily help with other disorders. But even things like depression, which is not a movement disorder, you can still interrogate the brain where you will notice pathology when you stimulate and record from. You can also use EEG. You can stimulate with TMS and then record the brain activity with EEG. Again, a fairly low cost tool equipment where you again get some indication. So there would of course, you don't base your diagnosis based on one of these methods, but together, they're fantastic. In fact, I know I'm rambling on, but just to show you, for example, I use TMS for pre-surgical mapping. So, for example, where the surgeon will tell me that he needs to remove a malformation in the brain, but he's worried that if he destroys part of the brain, this will get, if it's in the vision area, this might make the patient blind. So what I can do is actually stimulate the visual area to find out where those active neurons are and where the dysfunctional neurons are. Then I can tell him, okay, these areas are not responsive anymore to vision. You can go ahead and destroy it. And I've had probably 12 patients for vision, language, and nobody has lost any sort of function based on that. So it's also a new type of function, new type of research that I'm doing, but it's again, neurosurgeons really like it because it's just an additional sort of tool. So brain stimulation does have more than what it looks like. You can use it for diagnostic in a very powerful way. Yeah, sorry, it is a long tirade.
Sure.
So we've got another question.
Yeah. In one of the initial slides, you mentioned about the blood-brain barrier, and what comes to my mind about we can use this technique for effective drug use. Is this an area that you're looking at seriously? Because we have nutraceuticals, functional foods, even drugs that cannot pass the blood-brain barrier. But if your method can stimulate and allow some of these molecules to go in, then it could be quite effective in some ailments.
So yes, so this is definitely a very promising area as well. This is a little bit less about what I do, but I do have collaborators here in Toronto that do specifically this. Now, it is promising in the sense, yes, you can target and open the blood-brain barrier at a specific location and let the molecules out. What we are still working out, though, is how long it remains open. And, if it remains open for too long, you're letting molecules that you don't want to go out, right? So we're still it's not fully it's not a ready-made method yet, but it is definitely in terms of research. That's exactly what you said. Is exactly what we're trying to do. Not me personally, not our lab, but our collaborators. If you want, feel free to email me. I can get you more up-to-date information on this, and I can get you some contacts as well. What I know is from hearing from my collaborators, but this is not a space that I'm directly involved in. So it could be that there's, newer advances where they figured out protocols that work a little bit better. So yeah, feel free to email me, but it's definitely a very exciting method.
Maybe I'll just get on that opportunity again to ask you, what's the necessary technical platform that would be needed, and how many healthcare professionals, and which kind of healthcare professionals would be needed for these kind of research, I would say?
Yeah. So to give you an example, my background is I was trained in psychology. I have zero medical background. So it does not require a very specific type of an understanding of a brain. So these are things that you can learn from textbook, that's fine. But the practical application is what it is. You need an experienced person to teach you how to go about doing it, because there's also, so you can't just put the transducer and say, oh, I'm going to simulate. You do have to calculate, you do have to do a little bit of acoustic modeling and things like that. So we have collaborators that develop all these. So we have all the components that are available. So if I, for example, were to train, so my aim is to come to Mauritius every once a year, for example. I could run, say, workshop, and I could train people to run something like this very quickly, because the sort of the mechanistic part of it is you just need the stimulation. Of course, you do need MRI, anatomical MRI, to be able to know exactly where you're stimulated. But in a hospital setting with patients, that's usually they have an MRI. And the modeling is already, our collaborators has it. It's open source, free. So all the pieces are there. It just needs someone to show and give some experience to students. So my students are mostly undergraduate, where I will train them for maybe a month of stimulating and guiding them. The modeling can be done remotely. And then it's mostly the practical aspect of it. Once they gain the practical experience, it's pretty straightforward. So the main issue is what, of course, you need the ultrasound, that's a little bit more expensive. But there are a lot of companies out there that are willing to apply for grants to work to develop newer machines. You need the ability to do modeling, so a powerful laptop is good enough for that because it's the modeling itself is free, and then I can teach that remotely. And you also need a neuronavigation system, which is once you have the anatomical MRI, so you can track your transducer as you're stimulating, you can see what's underneath. So these are the technical things. Of course, there are ways around it. For example, with TMS, if I stimulate TMS and I get a hand movement, then I know for sure I'm on the hand area. So that's a different way of localizing function. So once I identify the hand area, then I can just place my transducer there, right? Then I don't need MRI, because if I stimulate here, I get a hand movement. So I know this has to be the hand area. So there's different ways. But to answer your question, all the components it's not difficult to train someone because they're all very user-friendly parts of it. The only tricky part would be the acquiring the equipment, really. That's really the issue. But in terms of acquiring equipment, we are more than willing. We collaborate with people from all over the world where we apply for collaborative grants. As you can see, foundations are more than willing to fund these type of research. So collaborations with Mauritius would be, perfectly feasible, whether in a sort of a physics or bioengineering or more of a health applications. These are potentials that are readily available, and off the top of my head I can think of ways to sort of apply for grants for that. So the short answer for the training is really not involved that much in it's just a practical experience. It's perfectly feasible to train someone. Thank you.
Thank you. Thank you, Dr. Nanku. Do we have any other question? No. Okay. So thank you again, Dr. Nanku, for your intervention. Just to point out, you're 8 hours behind us, so it's an early morning start for you there.
Yeah, sun is just rising now.
Yeah. Okay. So thank you very much for your contribution, and I hope
Thank you for the invitation.
this has really stimulated some possibilities for collaboration. Definitely the council will be liaising with whoever also who might have interacted online, maybe through some questions that we've not been able to pick up immediately, and then we'll feed that to you. And of course, keep the channel open for further discussion. So once again, on behalf of MIC, thank you very much for your intervention.
Thank you. Thank you. Yeah, feel free to get in touch and more than willing to collaborate with anyone.
Okay, thanks. Okay, so we've now reached the end of the presentations. So on behalf of MIC, we want to thank again all the presenters who have taken their time to come and discuss in fairly sufficient detail the research that they've conducted. We encourage a lot of collaboration, so we hope this is not really just the end. As you are aware, MIC is going to possibly launch another call for proposal. I don't know the exact timing, but health innovation will be definitely one of the areas also that are being considered. So please keep posted to the MRIC website, and we'll let you know also of any other possibilities for funding. And like Dr. Nanku just mentioned, do feel free to get in touch with him. We'll be sharing the contact details, the presentations. If you want to take up, possibilities of joint collaboration with him, you can start exploring, and then by the time we have a call for proposal, maybe this can mature. So I'd like also to thank the director, chairman, for being present during this session. I thank the technical team, my colleagues who've helped me put this in place, the technical team from the company who's put all the audiovisual setups, but this has allowed us to join online everyone. And thank you everyone for your presence here today. Just to remind you, there's some refreshment in the lobby before you leave. Thank you.
Thank you.